secondary cause of glaucoma. And although it's light to digest, it's difficult in reality to deal with, as it requires a multidisciplinary approach. So uveitic glaucoma remains a common and potentially blinding disease, and approximately happen in 10 to 20% of uveitic eyes, and it tends to be aggressive in nature rather than primary glaucomas because of the rapid progression to involvement of the optic nerve damage in comparison with the primary pathologies. So the mechanisms of having high IOP could be one of the five. Initially, it can be an inflammation causing blockage of trabecular meshwork by the debris and the cellular reaction. Second of all, it can be trabeculitis that is causing edema of trabecular tissue, and as a result causing elevation of IOP. Third of all, can be development of anterior synechiae formation and causing angle closure in those kind of eyes, or even causing iris bombae or posterior synechiae development. And last but not least, also don't forget the steroid response caused by the long time and the frequency of steroid use for those kind of eyes. So the combination of iritis along with the glaucoma can be caused by different etiologies such as sarcoidosis, GIA, parasplenitis, Posner-Schlossman syndrome, and also others like Fuchs heterochromic iridocyclitis, Behçet disease, and some infectious pathologies like congenital rubella, syphilis, herpes, or acquired immune deficiency syndrome. And so what are the most common association between iritis and glaucoma? What are the most four? Anyone is aware among those? GIA, correct. Fuchs is true. Herpes, correct. And the last one is Posner, correct. So, sorry, it's herpes, you're right, and Posner-Schlossman, GIA, and Fuchs. So also the uveitic glaucoma can be further divided into acute cyclitis or iridocyclitis versus chronic. In the acute events, the patient will experience sudden onset of pain, photophobia, ciliary flush, and sometimes also pupil constriction in the involved eye. Flare, cellular reaction, chorotic precipitate can also be there. And usually in the acute phases, the pressure is actually lower in that eye in comparison with the fellow eye that is disease-free. The chronic iridocyclitis, usually after months or weeks of having the disease uncontrolled, the patient can develop a chronic stage, and it usually comes in remission and exacerbation. And it can be complicated by posterior synechiae development, peripheral anterior synechiae, cataract progression, band keratopathy, or development of glaucoma. So we're going to target the few diseases accordingly. So the sarcoidosis, the clinical presentation, it's usually a multi-system, as we said, inflammation that affects younger age group, that's usually with African ancestry. And it causes a non-caseating granuloma in the body. And what is the triad to diagnose a sarcoidosis? It's usually the pulmonary hilar lymphadenopathy, along with the peripheral lymphadenopathy, and lastly, the cutaneous lesions. The ocular manifestation of the sarcoidosis can be one of those forms: the chorioretinitis, the retinal periphlebitis, optic nerve involvement, lacrimal glands sometimes as well. 15% of the sarcoidosis can have the iritis, with the KP's presentation, and 11% can have iris nodules. 10% of those eyes can develop actually glaucoma. And the mechanism of glaucoma development in sarcoidosis is the obstruction of trabecular meshwork by the inflammatory debris or the presence of nodules that are Kopay and Busaka, depending on the border, the iris border sections. The diagnosis is usually the elevation of ASE levels in the blood. The GIA, the demographic or the background of the iritis is usually 16% of patients that have GIA can actually have iritis and can be acute and sometimes can be even asymptomatic. This is why in general hospitals they get referrals for uveitis workup in patients that are recently diagnosed as a GIA and usually presents in the early childhood up to the adulthood life. Markers, inflammatory markers can be positive as well, like the rheumatoid factor, the ANA positive, the HLA, sometimes B27 also. And 67% of those cases will have a poor prognosis if the uveitis occurred before the joint pain or before the arthritis developed. Pupillary block is one of the commonest presentation of those eyes, and it's usually difficult to treat because of the need of steroids and anti-glaucoma. And also it carries an unpredictable surgical outcomes for the control of pressure. And the early intervention is usually very critical and crucial in those kind of eyes. So moving to the next pathology, we have the parasplenitis. The clinical features can be snowbanking, snowballing, retinal periphlebitis, CME or development of cystoid macular edema. 8% of those eyes in one study showed that they can have glaucoma. In one of those mechanisms, it can be development of peripheral anterior synechiae, iris bombay, or even having a new vascularization. The management, again, is controlling the inflammation, giving aqueous suppressants, controlling the inflammation, topical and sometimes even systemic in those kind of eyes. Moving on to the fourth commonest is the Posner-Schlossman. We have condition in younger age group usually, and most of the time it's linked, theoretically speaking, to GI symptoms, peptic ulcer, and so on. And sometimes they have a positive even gene involvement, HLA-B W45 in 41% of the cases, more than 1/3 of the cases can have this involvement as well. And there are theories about the herpes to be part of or the main cause of the herpes of the Posner-Schlossman. Symptoms are again the same as any uveitis, blurry vision, halos that are lasting hours to weeks. And the hallmark of the diagnosis is having the unilateral disease, having an open angle, and also marked elevation of pressure during the time of the iritis attack. It's usually exceeding 35, so 40 to 60 millimeters of mercury during the attack. And it's characterized by return to normal baseline of pressure between the attacks. So this is another way to diagnose it, and it's usually a diagnosis of exclusion. And almost sometimes they have very mild to minimal reaction in the anterior chamber, so it can be easily missed. The risk of glaucoma actually rises as the number of years of the eye being involved increases. So if the eye is involved more than 10 years, it increased the twofold the involvement of or reaching to the point of glaucoma. Fuchs heterochromic iridocyclitis. It's usually a unilateral presentation as well, and it affects third to fourth decade of life. Men and women are equally involved. And again, the way of presentation would be mild chronic anterior uveitis that's often asymptomatic with a hypochromic iris in the involved site. And it's usually more evident in white people more than blacks because of the level of pigmentation, so 92% in white individuals and around 67 in darker skinned people. And it's characterized by the fine stellate capes on the lower half of the cornea. And the incidence of glaucoma can be as high as 60%, and the angle, despite that, remains open with absence of synechiae, and medical management is success is actually less than 50% of the time, and the requirement of surgical intervention would actually be beneficial if the patient fails to respond to the medical management. And the success in one of these studies reaching 72% with a trap, along with at least one injection of 5-FU. So I'm gonna here give you an algorithm of managing glaucoma cases. So it requires a dual focusing on the inflammation control and also the IOP lowering therapy. So for the inflammation part, we need to treat the patient aggressively. So treat the specific cause. If it was caused by a virus, we have to prescribe antiviral and so on, along with the use of steroids or immune modulatory therapy tailored to the pathology. And we have to get it controlled as much as possible before doing any further steps. The IOP lowering is also very critical in those kind of cases, and we'll go through them in a while. So the medical management, steroid, as we mentioned, either topical, periocular, intraocular, systemic sometimes. NSAIDs can be also used. Immunosuppressant or a steroid-sparing agent, biologics, sometimes can be used as well. Mydriatic will have a great role in preventing the development of posterior synechiae, and usually we avoid the cholinergic agents and the prostaglandins in active inflammation phases. So for the preferred glaucoma medication, the first line are usually topical beta blockers, alpha agonists, carbonic anhydrase inhibitors, the rhokinase inhibitors. And in cases of emergencies or a very high pressure with the event of an active inflammation, hyperosmotic plays a great role to lower the pressure at the same time while the active phases are there. And we have to be cautious of using cholinergic agents like pilocarpine and prostaglandins during the acute active inflammatory phase. So for the surgical management pearls, so step 1, avoid surgery while we have any active inflammation. Use the least invasive that's actually effective for that eye. And laser is superior to surgical intervention in cases of first presentation or in cases of not a complete occlusion or fibrin is blocking the view. And we have to be aware also about that laser is not to be used as a first line of management, like laser trabeculoplasty. So be cautious of using those. And in some cases, they say it's complete contraindication. And choosing the wise surgery is also very important. Filtering procedure like trap or tube. And we'll discuss the challenges that the surgeon might face later on. So the surgical options, as we said, the trap carries a high risk of failure. So drainage devices, it is the most efficient option of good outcomes in controlling uveitic glaucomas. Pediatric cases, we can think or offer the patient goniotomy in selective cases, especially in younger age individuals or in the childhood phases. Can be a great option. Mixed, however, it's still not studied well, and there is a fear of past development because we are targeting the angle, so there might be a fear of a reaction from the body and causing further past rather than beneficial outcomes. Cyclodestructive is usually left for cases that carries a lower visual potential or that are aphakic or pseudophakic with limited visual rehab in that individual. So the challenges, the thing is that it carries a lower risk of success in comparison with the primary open angle glaucoma cases. And also that those individuals are usually younger age group, which carries high risk of failure, inflammation, fibrosis, the risk of developing fibrosis, scarring is there, and it requires multidisciplinary approach earlier before the intervention. Sometimes we need to admit the patient like 3 days prior to the procedure, give the patient systemic medication, and sometimes even more than that. In the GIA, for example, here, the regimen here in KCASH, we usually give systemic medication 10 days before the glaucoma surgery. The timing is very critical to before doing the surgical intervention. Must be planned when the eye is quiet as possible, and usually in a period of at least 3 months, having a quiescent phase with no further activation. Mix has a role, but still, as I told you, it's still not well understood, and you have to be cautious about development of peripheral anterior synechiae. So lastly, the special consideration that infectious uveitic glaucoma is we have to initiate the therapy the earliest the patient was diagnosed, like CMV virus. We have to give antiviral medication significantly to improve the long outcomes, IOP control, and prevention of further disease progression. Young patients and the surgery as well. So the younger the uveitic glaucoma patients are, often carries higher risk of failure rates and requires stepwise tailored approach, potentially involving earlier mix in the early childhood or drainage devices placement later on as this individual is aging. So I'm gonna open the floor for any questions, anything for concerns. Thank you so much.